Welcome to Roadmap to Residency Evidence-Based Applications. So here we have a question with us. A 25-year-old woman presents to the emergency department with a swollen and painful right ankle following a fall while playing soccer. On examination, her ankle is warm, erythematous, and tended to touch. Lab tests reveal an elevated white blood cell count and increased levels of C-reactive protein. Histopathological examination of a biopsy from the affected area shows neutrophil infiltration into the surrounding tissue. Which of the following processes best describes the initial cellular events in the pathophysiology of acute inflammation in this patient's ankle? Number A, margination and rolling of leukocytes, release of chemical mediators such as histamine and prostaglandins, adhesion of leukocytes to endothelial cells by selectins and integrins, migration of leukocytes through the vessel wall, phagocytosis of microbes and cellular debris by neutrophils. We will come back to this question, but by now you have understood that in this video, we will be discussing in brief about acute and chronic inflammation and wound healing by fibrosis and formation of granulation tissue. So acute inflammation is a transient and early response to injury that is characterized by the release of numerous chemical mediators and leads to stereotypical small vessel and leukocyte responses. It is characterized by the release of numerous chemical mediators and leads to stereotypical small responses, and it is not a synonym of infection. Now, there are three cardinal signs of acute inflammation. Number one is redness and heat. Then there is the cell swelling of tissues, and then there is pain. The redness and heat, these both signs are due to the histamine-mediated vasodilation of the precapillary sphincters in arterioles, which leads to flooding of the capillary network and dilation of capillaries and post-capillary venules. Swelling of tissues, which is synonymous with edema, is due to the histamine-mediated increase in the venule permeability. Edema refers to increased fluid in the interstitial space. Pain is due to prostaglandin E2, which sensitizes the specialized nerve endings to the effects of bradykinin and other pain mediators. Now, what are the stimuli of acute inflammation? It may be anything like infections, for example, bacterial or viral, immune reactions, for example, reaction to a bee sting. Other stimuli may be tissue necrosis, for example, acute MI, trauma, radiation, burns, and foreign bodies. Now, what are the sequential vascular events in acute inflammation? So number one, there is the vasoconstriction of arterioles. So first, there is vasoconstriction of arterioles. The first vascular event is due to the neurogenic reflex lasting only a few seconds. So and after that, there occurs the vasodilation of arterioles. So the arterioles are impermeable, small arteries that have a few elastic fibers and only 1 to 3 smooth muscle layers in the tunica media. The histamine and other vasodilators, for example, nitrous oxide, relax the vascular smooth muscle in the arterioles, which causes increased blood flow. And then histamine is released from the mast cells located in the interstitial tissues around these small vessels. And then there is the increased blood flow, which leads to the vasodilation of arterioles, and it increases the hydrostatic pressure within the lumens of the venules. Then there is the increased permeability of these venules. Now, venules are permeable. The arterioles are not permeable, but these venules are permeable. They collect the blood from capillary networks and have only 1 or 2 layers of muscle fibers and gradually merge to form veins. The histamine and other mediators contract endothelial cells in venules, producing endothelial gaps that expose a bare basement membrane. Tight junctions are simpler in venules than in arterioles. Therefore, they are easier to contract. Now, because of increased intraluminal hydrostatic pressure, pressure exerted by fluid in the venule lumen, a transudate moves through the intact venular basement membrane into the interstitial tissue. Swelling of the tissue. So the tissue swelling, that is edema, also called as tumor on old term, occurs when the net outflow of fluid from venules surpasses the capacity of lymphatics to remove the fluid. Now, it is also one of the cardinal sign of acute inflammation, as we have discussed earlier. The reduced blood flow eventually occurs because of the leakage of fluid into the interstitial tissue and increased uptake of the fluid by the lymphatics. Now, since there are the vascular events of acute inflammation, then obviously there are some cellular events of acute inflammation. So neutrophils are the primary leukocytes in acute inflammation. So the peripheral blood neutrophils are subdivided into a circulating pool and a marginating pool, those that are adherent to the endothelial cells. So the margination of neutrophils occurs in acute inflammation. The red blood cells aggregate into Rolex, that is a stack of coins in the venules. Now this Rolex is caused by fibrinogen, which is an acute phase reactant protein that is synthesized and released by the liver. The ROLU mechanically forces the neutrophils out of the central axial stream and pushes them to the periphery of the venules, called as margination. Now, the margination of neutrophils is not the same as the marginating pool of neutrophils, okay? It is only the thing that, for example, there is one vessel, okay? Let me draw it for you. So, for example, there is this vessel. Now, due to the Rolex formation of RBCs here in the center, then the WBCs or the leukocytes cannot travel in this axis, right? Now, they have to marginate towards the side. Now, this margination is called as the, now this phenomenon is called as the margination. No, there is rolling of neutrophils. Now, the rolling occurs in the venules and is due to the expression of selectin adhesion molecules of neutrophils and venular endothelial cells. The neutrophils adhere to the endothelium and then release adhere and then release as they circulate through the venules. So it is a continuous process. The selectins are very, very important in this process. So the L-selectin and P-selectin are important. Now, the L-selectin is located on the leukocytes, whereas E-selectin and P-selectin are located on the surface of the venular endothelial cells. Here you can see the circulating pool of neutrophils in a small vessel which move down the central axial stream. And here we can see the neutrophil margination in a small vessel here. The P-selectin is produced in the Weber palette bodies in the venular endothelial cell. Now, these Weber palette bodies are the glue factors of the endothelial cells because they synthesize the P-selectin, which is an adhesion molecule for leukocytes, and one Weber factor, the adhesion molecule of the platelet. Interleukin-1 and 2 necrosis factor stimulate the expression of selectin ligands on the surface of neutrophils and the expression of selectin molecules on the surface of venules. So you want to express the selectins on the neutrophils as well as on the venular endothelial cells where they will go and attach. So the binding of circulating neutrophils to E-selectin and P-selectin on venular endothelial cell is weak and transient, causing them to roll. So they bind, detach, they again bind, they again detach along the surface. I hope you understand this. So the form adhesion in the venules is due to the neutrophil expression of beta-2 integrins and venular endothelial cell expression of integrin adhesion molecules. Then there comes the transmigration, that is the diapedesis of neutrophils into the interstitial space. So the neutrophils moving along the venular endothelium enter the gaps produced by histamine-mediated endothelial cell contraction. Now, in this location, the neutrophils release the type 4 collagenase, which dissolves the basement membrane, allowing neutrophils to enter into the interstitial tissue. The platelet endothelial cell adhesion molecule, or PECAM1, is expressed on the surface of platelets, neutrophils, and endothelial cells. The plasma-derived fluid rich in proteins and cells accumulates in the interstitial tissue, and this is called as exudate or pus. And then there is the chemotaxis of neutrophils. The chemotaxis is directed migration of neutrophils. The neutrophils follow chemical gradients that lead to the infection site. There are many, many chemical mediators, and there may be C5a, leukotriene B4, bacterial products, and interleukin-8 to name some. And then there is the neutrophil opsonization. Here you can see the early transmission of neutrophils in acute inflammation and the neutrophil transmigration and immigration into the tissue. Here we can see, so whenever there is a tissue injury, it causes activation of vascular endothelium and there is increased capillary permeability and there is the release of chemical mediators for the cellular recruitment, and then the morphogenic neutrophils, macrophages, and lymphocytes, they all travel to form an exudate here. Now, that was all about acute inflammation. Now, let us talk about chronic inflammation. So, definition of chronic inflammation refers to a prolonged inflammation, weeks to years, that most often results from persistence of an injury-causing agent. The causes of chronic inflammation may be infection, which is the most common cause, tuberculosis, autoimmune diseases, example, rheumatoid arthritis, systemic lupus erythematosus, or SLE. Now, the chronic inflammation, we can see in the histology part, the tissue shows an infiltrate of predominant lymphocytes and occasional plasma cells. Now, granulation tissue, which is the hallmark of chronic inflammation, we can see the mixture of neutrophils and lymphocytes and plasma cells. Now, let's talk about the cell types that define the chronic inflammation. So, the monocytes and macrophages are the key cells. Other cells include lymphocytes, plasma cells, and eosinophil. The transforming growth factor beta is chemotactic for macrophages, lymphocytes, and fibroblasts. Now, since there is the destruction of parenchyma, so with loss of parenchyma, there is loss of functional tissue with repair by fibrosis. Now, the most important part is the formation of granulation tissue. Now, granulation tissue is a type of highly vascular tissue that is composed of blood vessels and activated fibroblasts. Now, these blood vessels are derived from pre-existing blood vessels and de novo from the endothelial cells, precursors, they created from the bone marrow. And this process is called as angiogenesis. Then there is the vascularization, which is essential for the normal wound healing. The granulation tissue is the precursor of scar tissue, and fibronectin is required for the granulation tissue formation. Now, wherever we talk about granulation tissue, we need to talk about granulomatous inflammation. So, granulomatous inflammation is a special type of chronic inflammation which is characterized by the formation of granulomas. What are the causes of granulomatous inflammation? The number one cause is infections. For example, TB and systemic fungal infections. Non-infectious causes of granulomatous inflammation, sarcoidosis and Crohn's disease. So the chronic inflammation with plasma cells, you can see in the figure number one, we can see here the eccentric located nucleus here. You can see here, this is the eccentric located nucleus, and we can see lymphocytes. Now you can see this is the diagrammatic representation. We can see collagen, we can see capillaries, we can see myofibroblast, we can see abundant macrophages and all. Now, this is a very important figure, a very important histological image that you need to remember, I hope, for the rest of your life. So this is the figure of granuloma, of granulomatous inflammation. And we can see here the epithelioid cells. These are the epithelioid cells. These are multinucleated giant cells here. And these are the lymphocytes here. Now, what are the different factors that are involved in tissue repair? Now, since there are inflammation, now then there is again healing by tissue repair. Now, there are different factors that are involved in tissue repair. Number one is vascular endothelial cell growth factor, which stimulates angiogenesis, repair of the tissue, and cancer angiogenesis. Fibroblast growth factor, which is responsible for the chemotactic for fibroblasts. Epidermal growth factor stimulates the keratinocyte migration and granulation tissue formation. Platelet-derived growth factor are chemotactic for neutrophil, macrophages, fibroblasts, and angiogenesis. Transforming growth factor beta are the chemotactic agents for macrophages, lymphocytes, fibroblasts, and smooth muscle cells. Interleukins and cytokines are very, very important. These stimulates the synthesis of metalloproteins. Now, these are the enzymes containing trace metals, for example, zinc, which are necessary for tissue uh, repair and tissue remodeling, and which of the following trace metal is very important for the tissue repair. Answer zinc, very commonly asked in the examination. Stimulates synthesis and release of acute phase reactants from the liver. The tumor necrosis factor activates macrophages and stimulates the release of the acute phase reactants. Now, the repair by connective tissue or the repair by fibrosis is a very important event in cellular repair. So repair by connective tissue occurs when injury is severe or persistent. The tissue in a third-degree burn cannot be restored to normal owing to loss of skin, basement membrane, and connective tissue infrastructure. So the steps in normal connective tissue repair includes, number one, the repair requires neutrophil transmigration to liquefy injured tissue and then macrophages to remove the debris. After that, the repair requires the formation of granulation tissue and the precursor which is a precursor of scar tissue. Now, this granulation tissue accumulates in the extracellular matrix and eventually produces dense fibrotic scar. Now, the repair requires initial production of type 3 collagen. Now, this type 3 collagen has a poor tensile strength and hence the wound can easily be reopened. Then there comes the dense scar tissue, which is produced from the granulation tissue, which contains the type 3 collagen that must be remodeled. Now, that weak collagen, that type 3 collagen, which was weak, now this remodeling increases the tensile strength of that type 3 collagen or that scar tissue. And the metalloproteinases, that zinc 1, replaces the type 3 collagen with type 1 collagen, which is now a strong collagen. So, first, You need to remove the debris, you need to remove the foreign bodies by macrophages, and then you need to form a scar tissue by the granulation tissue, and then there is the type 3 collagen. This type 3 collagen undergoes a remodeling and get transformed into type 1 collagen. Now, this is the basic difference between acute inflammation and chronic inflammation. So, the pathogenesis of acute inflammation include microbial pathogens, trauma or bonds, and chronic inflammation means persistent acute inflammation. The primary cells involved are neutrophils, and here monocytes and macrophages. The primary mediators are histamine, whereas there are cytokines. The duration is important. It occurs only for a few days, whereas there is weeks, months, and years. The scar tissue is absent in case of acute inflammation, as well as it is very commonly, or it is a hallmark of chronic inflammation. The main immunoglobulin is IgM, the main immunoglobulin is IgG, and here is our first question that we have discussed, and the answer is again margination and rolling of leukocytes. You can pause the video and go through the explanations. Again, we have one more question here. A 45-year-old man presents to the gastroenterology clinic with complaints of abdominal discomfort, jaundice, and unintentional weight loss over the past 6 months. He has a history of chronic hepatitis C infection and a significant alcohol intake of approximately 6 standard drinks per day for the past 20 years. Physical examination reveals hepatomegaly and ascites. Lab test shows elevated liver enzymes, bilirubin, and prolonged prothrombin time. Imaging studies demonstrate cirrhosis of the liver with evidence of extensive fibrosis. Biopsy of the liver reveals architectural distortion, regenerative nodules, and significant deposition of collagen-rich extracellular matrix. Which of the following cellular processes is primarily responsible for the fibrosis observed in this patient liver? Increased proliferation of hepatocytes, conversion of hepatic stellate cells to myofibroblast, transformation of Kupffer cells to fibroblast, metaplasia of biliary epithelial cells, or hypertrophy of sinusoidal endothelial cells. The answer is conversion of hepatic stellate cells to myofibroblast. Again, you can pause the video and go through the explanations. Thank you for watching. Keep studying hard.